Hello everyone and welcome to my talk. My name is Maria Richards-Brown and I'm a mental health neuroscience research assistant at University College London or UCL. I'm honoured to be speaking here today and talking to you about my paper, which is exploring patient and clinicians' perspectives on pharmacogenetic testing for antipsychotics. So to begin, as an overview, I will talk about psychosis. I will run you all through pharmacogenetics and a little bit about the GEMS study, which is a UCL study investigating pharmacogenetics as an intervention for optimizing antipsychotic prescriptions. I will then go into more detail about my study, which is investigating patient and clinician perspectives, and finish with an evaluation of the study and looking towards future directions. So psychosis is a broad symptom category characterized by hallucinations, delusions, catatonia, disorganization, and disordered thinking, all of which can lead to altered thoughts and feelings. Psychosis can occur in various mental health disorders, including schizophrenia. Schizophrenia, as an example, has a prevalence of 1% in the UK population. Antipsychotics are currently a first-line treatment for psychosis as recommended by the NICE guidelines in the UK. This is alongside CBT, so cognitive behaviour therapy for psychosis. There are several antipsychotics, so I've just listed a few here. Typical and atypical, with the atypical being the more recent generation antipsychotics that apparently have a smaller side effect profile. However, treatment failure, so when patients do not respond to antipsychotics, which occurs in about 30% of schizophrenic patients. Adverse drug reactions such as weight gain or decreased libido, as well as lack of insight into the disease, contribute to high discontinuation rates. And unfortunately, discontinuation of antipsychotics is associated with nearly double the rehospitalization rates compared to those who continue their treatment. So it's unsurprising that there are mixed views of antipsychotics, given the negative side effects and often ineffective treatment. So concerns around this variability and whether individuals will respond to antipsychotics or not has led to the development of more personalized therapeutic strategies, also known as precision psychiatry. And accordingly, pharmacogenetics investigates how genetic profiles influence drug metabolism and thus response to medication. So there we have an enzyme that is catalyzing a substrate into two different products. And so of particular interest in pharmacogenetics is the cytochrome P450 or CYP enzyme family, which plays a prominent role in drug metabolism. And we're interested in the genes that code for these enzymes as they are critical in determining an individual's metabolic capacity. So for example, CYP2D6 has over 100 genetic variants and codes for the enzyme CYP2D6, which is responsible for the metabolism of about 25% of all medications, including SSRIs, opioids, beta blockers, as well as our focus, which is antipsychotics. And so the idea is that your genes will determine your metabolic capacity, so how many of these enzymes you have, and thus how you metabolize drugs. So here we have a scale from poor metabolizer to ultra rapid metabolizer, which is indicative of your enzyme activity, and this is what your genetics determines. For example, if you're a poor metabolizer of a certain enzyme, it means you will metabolize a drug slower, the drug will stay in the body for longer or at higher plasma levels, and you will therefore be at an increased risk for adverse drug reactions. Therefore, if you're determined to be a poor metabolizer, pharmacogenetics may recommend a lower dose of a certain drug or an alternative drug for which you are a normal metabolizer of. In contrast, if you're an ultra-rapid metabolizer, this may mean that you metabolize drugs faster due to your genetics, and this means less of the active drug will reach systemic circulation and thus could inhibit therapeutic efficacy. In this case, pharmacogenetics may recommend a higher dose of that drug or an alternative drug that you are a normal metabolizer of. So the current literature on pharmacogenetics and its clinical use is ever growing. So there's a recent prospective randomized clinical trial known as PREPARE that was conducted across 7 countries, including the UK. These researchers found that using a pharmacogenetic panel did significantly reduce adverse drug reactions by 30%, which demonstrates the clinical utility of pharmacogenetics in general medicine. Looking to specifically psychiatric patients, so those with schizophrenia, depression, or bipolar disorder, these researchers found that pharmacogenetic testing also led to a significant reduction in adverse drug reactions, as well as fewer hospitalizations and fewer readmissions. So there is current evidence in general medicine and psychiatry for the clinical utility of pharmacogenetics. However, that is not to say that it is not mixed, especially when we look specifically to pharmacogenetic testing for antipsychotics. There are mixed findings as to whether it's clinically useful. And this recent systematic review suggests that pharmacogenetics is a promising approach to personalizing prescribing of antipsychotics, but there are still limitations in the literature, such as lack of diversity and modest sample sizes, and these may explain inconsistencies. So now this is my team, and I'm going to talk to you a bit more about what we're doing at UCL. So GEMS is a broader study that I am working within, which is investigating the clinical utility of pharmacogenetic testing for antipsychotics. On the left here, I have the stages of the study, which I won't go into too much detail, and I hope you can ask questions afterwards if you're interested. The aims of the study is to see whether pharmacogenetics can reduce adverse drug reactions, whether it is cost effective, and whether it's deemed acceptable by patients and clinicians involved. And the sample criteria for the patients are that they're over 18, they have a diagnosis of a psychotic disorder, and are currently prescribed an antipsychotic. And so what my paper investigates is whether it's deemed acceptable by patients and clinicians. So my specific aims are whether patients and clinicians understand the genetic report, to see what the clinical utility of pharmacogenetic testing is, to see whether pharmacogenetics can promote shared decision making, which I'll go into more detail in later, and to see what barriers patients and clinicians identify. So there are 2 separate methods that I'm going to talk about as I investigate patient and clinician perspectives separately. So with patients, we did an 18-question survey that was administered to 22 patients, and the survey was co-produced with service users to ensure that it reflected relevant topics and to ensure the wording was sensitive and comprehensive. And given that the questions had both open and closed questions, Likert scales, as well as yes and no questions, this warranted a mixed methods analysis. When investigating clinicians' perspectives, semi-structured interviews were conducted that were around 30 to 45 minutes long, and this was a qualitative thematic analysis done using in vivo to see what themes emerged. Firstly, looking at the understanding of the genetic report. So we have here a bar chart of patients' understanding of the genetic report, where 1 indicates a patient not understanding the report at all, and 10 indicates that they fully understood. The mean here is 7.29, indicating a moderate level of understanding of patients of the genetic report. However, as you can see, it varies and it does span the entire scale from 1 to 10. We heard from a patient that the report was important for them to try and understand the relationship between enzymes and medication. And there is indication that they could understand this from the genetic report. However, a clinician did indicate that the report is maybe undetailed, and for those with no knowledge of medicine, it may need to be clearer. And this was echoed by a participant patient who said that it could be more user-friendly, and another clinician did suggest a summary highlighting key points would be beneficial. and that this would be beneficial for both patients and clinicians who want to and are able to understand their own genetics and thus the medications they're prescribed. When looking at the clinical utility of pharmacogenetics, I've divided this into 3 separate themes. So retrospective utility was spoken about, in which pharmacogenetic information can validate previous clinical decisions. So a clinician described how they had reduced the dose of one patient and as they were not tolerating the medicine well, and this was validated by the report that demonstrated that they were a slow metabolizer. Equally, pharmacogenetics can explain previous intolerability to patients, not only to clinicians. As one patient said, it was interesting to see that medications that I'd taken in the past were not a good choice for me. So it can be validating for both patients and clinicians to look over their history and see how the pharmacogenetics report can inform them of their history. Clinical utility with regards to changes of medication. So pharmacogenetics did inform some dose adjustments, with one clinician stating that they were partly guided by the report when changing treatment. However, sometimes the pharmacogenetic results and the clinical presentation of a patient did not match. As one patient was described to be a poor metabolizer, and thus you would expect worse side effects. However, the clinician described that medications were well tolerated. So this just goes to show that expectations of both patients and clinicians should be managed, as pharmacogenetics is not guaranteed to lead to any medication change. And then looking to predictive utility. So most clinicians felt that pharmacogenetics is more important when looking to the future. So this is a report that you can have on your healthcare records and can inform all future prescribing decisions. Moreover, it was thought that pharmacogenetics would have more utility for first-time patients, whereas a lot of patients that we spoke to had been on medications for several years and had already been through trial and error prescribing. One clinician described that they thought it would be more valuable earlier on in people's journey to prevent the trial and error approach to prescribing and get something personalised straight away. So when thinking about shared decision making, I hypothesised that pharmacogenetics would lead to an increase in shared decision making, which is to ensure that patients are informed, involved and influential in decisions surrounding their medications. I thought that as this intervention involved a discussion of the genetic report between the patient and the clinician, that this would lead to patients feeling more informed and involved. So that's what I investigated here. On the left, I asked patients' feelings of involvement in medication-related decisions in the past 5 years, so before pharmacogenetic testing. And then on the right, I asked about involvement in medication-related decisions after their pharmacogenetic test. And the mean is higher following pharmacogenetic testing. However, I did do a t-test and it was not statistically significantly different. Nevertheless, a patient said that they really wanted to know what was happening in my body, which shows the importance of the discussion of the report and informing patients. One clinician did state that patients report feeling more empowered and better informed. A patient said that this can make prescribing more bespoke and thoughtful. And finally, a clinician stated that it feels more collaborative using this pharmacogenetic information. So although I do not have quantitative or statistical evidence to suggest that pharmacogenetic testing led to increased shared decision making, the qualitative notes and quotations of what both patients and clinicians are saying indicates that it is leading to perhaps more collaborative care. Finally, looking towards barriers to pharmacogenetics, the predominant barrier identified by both patients and clinicians was accessibility. So first, in terms of physical accessibility, patients noticed that some individuals that are more severely unwell may struggle to provide a saliva or blood sample or struggle to go into a clinic to do so if they're housebound. So it's just making sure that research teams and healthcare teams will go to these patients perhaps and obtain the sample themselves. Another patient suggested the language is quite advanced, and this is for both patients and clinicians, so it's making sure that the information is accessible and that patients can understand why pharmacogenetic testing could benefit them, and also to ensure that clinicians have a comprehensive understanding of the report, ensuring that they can then deliver the report discussion adequately with the patient. So not only should there be maybe a more user-friendly report for patients, but more training in pharmacogenetic testing for healthcare professionals as well. So one clinician rose patients' consent as a barrier, especially amongst this demographic of individuals with psychosis who may be experiencing high levels of paranoia or hypervigilance. They stated that you will get some patients who won't want it, and this is something for us to be considerate of and careful of when we are consenting patients into the study. And finally, logistical barriers were raised, so cost. One patient did say that they were unsure whether all individuals would be able to pay to get it done, which is why in the UK we want to provide evidence for it to be implemented in the NHS so that patients do not need to pay. And another barrier was time, so both patients and clinicians noted this, and clinicians, as we know, are pushed for time already in their appointments, and having another report to discuss with patients could be seen as an additional burden. So it's just finding ways to implement this into routine care that does not burden the clinician. So key findings are patients and clinicians overall were very positive about pharmacogenetic testing. They both could and wanted to understand the pharmacogenetic reports. So it's important not to underestimate what patients want and can understand. Patients and clinicians both believed pharmacogenetics could help with shared decision making, which is important when we are promoting person-centred and collaborative care. Nevertheless, there are barriers noted by both patients and clinicians that need to be addressed. Strengths of my paper would be that it's the first study in the UK to investigate patient and clinician perspectives, specifically those that have undergone pharmacogenetic testing themselves. I think the fact that the survey was co-produced with service users is very important in ensuring that the research being done is relevant. And the mixed methods allows for both breadth and depth in my analysis of patient perspectives. However, small sample size of both patients and clinicians does mean that this may not fully represent all individuals with psychosis, and further the sampling bias, as these are participants of the GEM study, it means that they may already have a positive view of pharmacogenetic testing given that they are participating in it, and it's important to get a wider range of views of individuals across the healthcare system, and those that may refuse pharmacogenetic testing as well. So looking towards next steps and clinical implications, I think pharmacogenetic training to healthcare professionals is very important. Managing patient but also clinician expectations is important too. And as always, to research more diverse populations, especially when genetic diversity can contribute to these pharmacogenetic reports, it's important that we ensure that underrepresented groups are being recruited into these studies. So that is all from me today. Thank you for listening, and I'm happy to answer any questions.